So I'm excited to introduce our speaker today. He's new to PMD Alliance as far as speaking on one of our programs, so it's very exciting, but I happen to be lucky to live in the same city with him. So this is Dr. Mitesh Lotia. He is a fellowship-trained movement disorder specialist. He actually is with the Abbott Health Neuroscience Institute as their medical director of movement disorders. And he sees patients with Parkinson's, dystonia, Tourette's, and other movement disorders. He is very knowledgeable, very kind. He's a founding member of the Functional Neurological Disorder Society, an active member of the American Academy of Neurology and the Movement Disorder Society. So we are excited to have him as our speaker today. So Dr. Lotia, welcome. And I am going to pass this over to you.
Thank you so much, Anissa, for that. And again, thank you for having me on this wonderful platform. Good afternoon, everyone, or greetings, I would say. I know there are people from different regions, and I really appreciate you all coming online to listen to some of the conversation. Education is very close to me. Half the times when I'm seeing patients with Parkinson's or other conditions, I want to make sure we are making our decisions together. And in order for you to be involved in your own care, the knowledge for the disease is equally important. Knowledge is power. So this is very close to me, and I really, really feel that we all should be in it together. So again, I thank Abbott and PMD Alliance to get this program together so we can communicate with a lot of our patients across. We'll keep this very casual. Feel free to ask questions. Idea is for you to just learn some basics about the deep brain stimulation therapy. Again, we'll talk about generalized ideas, but again, as a reminder, a lot of this is intended for education, not necessarily for your particular situation as such. So be mindful of that as we think it through. All right, so let me just share the screen and make sure that you all can look at the screen and go from there. And so I'm okay. Just want to make sure. Just let me know if you all see the right screen. Thought I just had it.
Don't you love when you don't try, it comes up really fast, and then when you're trying, it doesn't want to work for you. That's the way technology works.
I know, right? Okay, how about now? Good?
It is still processing. Yes, perfect.
Okay, great. All right, everyone. So again, welcome to the discussion about our program. So we'll just get, oops, sorry. I think, there you go. All right, so we'll just start with a very interesting story of one of the patient that has been living with Parkinson's. So some of us can relate to it.
And I've had Parkinson's about 10 years. The main symptom that really grabbed my attention was when my hand started shaking, and it was violent. I generated a spreadsheet of 43 different symptoms that I had. Like, I lost my sense of smell. Of course, my balance was terrible. I was unable to sleep at night. Most of the time I'd sleep 2 hours, that'd be it. And so then I went back to doctors time and time again, and it took them 3 years to fully diagnose me. They said, you have Parkinson's and your whole life's going to change. Really a hard thing to swallow is that, hey, I'm not going back to work anytime soon, maybe never, because I was a full-time engineer, plus I ran a company. I used to work 12 to 14-hour days, 6 days a week. I was not able to sculpt any longer. And so that was a real tough thing for me because I'd been sculpting for 15 years to get to that point. Like, wow, I really got it. And then it's gone.
All right. So just again, the perspective is that it can change everyone's life that is involved, not only the patients, but their loved ones in many different ways. So today what we want to talk about is we want to cover a lot of different symptoms that patients may have with Parkinson's disease, how currently the diagnosis is being done, how do we treat the motor symptoms, and then what is the role of the deep brain stimulation or DBS to manage the symptoms of Parkinson's. So, Parkinson's is becoming increasingly prevalent. We believe it affects 1% of population, but maybe more. Worldwide, we think about 7 to 10 million people are affected. In US, it affects about 1 million individuals. And back from the data, about 60,000 newly diagnosed patients were coming through, but more recent data we have that actually says that about 90,000 new patients are diagnosed every year. So we do believe that there is increasing prevalence of Parkinson's. One of the biggest reasons we believe is that we are living longer with other comorbidities being managed. However, there are other factors that we're looking at too, especially the environmental exposure. So, there are many factors that are being looked at. Typically, we all understand that Parkinson's affect more older individuals. So 50 to 65 is a typical onset. But again, we see patients who are very much younger, even in their 20s, or many who are older in their 70s to 80s as well. Depending on where they are in their journey, one of the first symptoms could be much different, but typically they have slowness and balance issues or tremors. It does tend to be a relatively slow progressive condition. It does tend to affect men more than women. So far, we haven't identified any particular socioeconomic status, but we do believe that in terms of access, lower socioeconomic status and our African-American communities do tend to be a little bit underprivileged when it comes to getting access to care. Back in the days, we thought it's not due to any genetic mutation, but we have identified multiple different genetic mutations. And at this time, we believe somewhere that 8 to 10% or even up to 12 to 14% patients with Parkinson's may have it due to a genetic mutation. Overall, when there is a family member, especially first-degree relative, there is a slightly increased chance of developing Parkinson's. So we are looking at that as well, as we kind of try to understand this a little bit more. So what really causes the symptoms? So primarily, we believe it is due to a toxic protein called this alpha-synuclein that then gets aggregated into forming another toxic protein called Lewy body. And in a typical Parkinson's patients, those Lewy bodies get deposited into the middle part of the brain that affects the neurons that produce the chemical called dopamine. And when those neurons that are producing the dopamine, when they start disintegrating, that's when people start having the Parkinson's symptoms. So this is a DAT scan, which is a special scan that we look at the levels of dopamine producing neurons. And you can see it's a nice comma-shaped finding in those DAT scan individuals. So you can see the head and a tail in the deeper parts of the brain that is of a normal individual. But in patients with early Parkinson's, usually what we see is that there is loss of tail, usually on one of the scans. So this is one way of saying that they may have a primary Parkinsonism. It still does not tell you whether it is, typical Parkinson's disease versus some of the atypical Parkinsonism. But it can definitely help differentiate between essential tremor and Parkinson's. Essential tremor is another condition that can mimic sometimes the tremors that we may see in Parkinson's. Again, we believe it is a combination of genetic and environmental factors that usually contributes to the Parkinson's symptoms. We are still learning. as we understand this better. So what are the typical symptoms? Often patients feel that, oh, our loved ones have to have tremors, but a lot of patients actually don't have a tremor. If they do, then they have what we call as a resting tremor, meaning in the beginning, it almost always starts on one side, and typically we notice it when we are not using the arm. And so typically your arm is at rest, and that's why you notice it. And but more importantly, what we see is there is definitely a reduction in the voluntary movements, and the movements are very, very slow. And there may be some stiffness associated with that as well. So the key criteria for the diagnosis is slowness in the movements, not necessarily the tremors. Slowness and balance issues are what we are looking for when we are diagnosing people. We try to divide the Parkinson's symptoms into motor symptoms and non-motor symptoms. Motor symptoms are the stiffness, slowness, the tremors, and the balance issues. The non-motor symptoms are a lot of fatigue, lack of sense of smell, constipation. There may be some weight loss, sleep issues. Again, individuals may get affected differently. What we say is that by year 5, almost everyone has at least one non-motor symptom, which could be even lack of sense of smell or dream enactment. But they do go hand in hand with the motor symptoms of Parkinson's. And it's important to know that. It's important that those non-motor symptoms are addressed as well, especially as we focus on improving the quality of life. But sometimes some of the symptoms can come in much earlier, such as constipation and lack of sense of smell. So we have to keep an eye on those too. As we understand Parkinson's disease, we don't think of this as a single entity. We believe it's more of an umbrella of a lot of different symptoms. So often patients can have variety of symptoms even within that umbrella, with some generalization. So as I said, the slowness and the balance issues are something we see routinely. But then, some people have more tremors, some people have less tremors, some people have more balance issues, some people have less balance issues, really depending on how that particular individual may be affected. These are some of the pre-diagnosis non-motor symptoms that we see. Again, lack of sense of smell, acting out of their dreams, constipation. So oftentimes we have people like, oh yeah, our loved one have been yelling, kicking for almost 10, 15 years before even any of these symptoms began. Versus some are like, well, I've lost my sense of self for the last couple of years. Well, I've had constipations for 5 years. So many of these symptoms can predate, the onset of motor symptoms by many, many years. But typically at the time of the diagnosis, majority of the patients, they have to have the slowness on their exam, and a very peculiar kind of slowness called as bradykinesia that we mainly determine on exam. They usually may or may not have rigidity or tremor. Later on, some of these patients may go on and develop the dyskinesias, medication-induced dyskinesias. So then how do we come about a diagnosis of Parkinson's? It is still, to date, a very clinical diagnosis where generally you meet with a neurologist, preferably a movement disorder neurologist, but even general neurologist, where you discuss your diagnosis and a lot of your symptoms, the slowness, stiffness, balance issues, and as we talked about other non-motor symptoms. It is then followed by a routine neurological exam, but also a focused movement exam where we're looking for a peculiar kind of slowness on your exam findings. We then discuss a diagnosis. We talk about whether to start the medications or not. The medications are predominantly replacing that dopamine that is missing in the brains of our patients with Parkinson's. And then we look at how individuals respond to the Parkinson's medications, and we decide the diagnosis. So sometimes it may take about a year or two before we confirm that, okay, we are dealing with a typical Parkinson's disease and not any other reason for Parkinsonism. So many a times, a lot of patients are said, well, I was told I have Parkinsonism, but I don't know if it's Parkinson's disease or not. So there are many reasons people may have Parkinsonism. So the role of the neurologist and your doctor is to figure out whether that Parkinsonism is due to Parkinson's disease or other symptoms. For example, patients who may have been taking some medications that can be contributing to some of those symptoms. They may have severe depression, which may mimic Parkinson's, or some other atypical forms where they have some symptoms of Parkinson's, but other symptoms that may point towards some more problems like cognitive issues or severe autonomic dysfunction, etc. Sometimes we may add these diagnoses. So we talked about the DAT scan, which is the special molecule that binds to the dopamine-producing neurons, and it is positive in patients who have primary Parkinsonism due to the alpha-synuclein, but it usually is normal in patients who have essential tremor or medication-induced Parkinsonism. Lately, a skin biopsy has been approved, and sometimes we resort to that. And we might order MRI sometimes, not to rule out Parkinson's, but to look at any other causes that could explain some of the symptoms that they have. So it really depends on a lot of other exam findings on that visit, and that's how we kind of come to a conclusion. But still, majority of the time, it's a clinical diagnosis that we use. So many times we don't even do any investigations. It's purely clinical diagnosis, and we go from there. Once a diagnosis is made, we talk about how do we treat it. Currently, the idea is that we don't have a cure. However, we have some really good treatment options that can replace the dopamine and alleviate a lot of symptoms that may be related to Parkinson's. But then we also talk about lifestyle modifications, which includes utilizing appropriate diet, and more importantly, adding exercise or active lifestyle. And the combination of all of these things is the ideal way to treat a lot of patients with our Parkinson's. As I said, medications-wise, one thing is to treat the slowness, stiffness, the tremors, and the other symptoms such as constipation, mood issues, sleep issues. We need to focus on treating that too, because again, idea is to help improve the quality of life. As the symptoms progress, as the disease progresses, some of the symptoms may get worse. For example, sometimes tremor gets severe enough that they start affecting a lot of routine despite of the medications. Some people may develop fluctuations and dyskinesias, and that is where the role of the advanced treatment option comes in, such as the deep brain stimulation. So we'll talk about that as well. Currently, the medications, as I said, the majority of the focus is on replacing that dopamine that is missing between the neurons. So the way neurons talk to each other is via a space called as synapse. And in that synapse, basically, the dopamine is released from one neuron to the another, but that's what is lacking in a lot of our patients with Parkinson's. So the main treatment for replacing that dopamine is the carbidopa-levodopa, in which the levodopa is the main substance. Currently, that is the best medication option that we have, because that is the one that directly replaces that dopamine into those neurons of our people with Parkinson's. Other group of medications are called dopamine agonists, which makes the brain believe that there is more dopamine available. So it kind of works out in the synapse, and it helps the levodopa work better, or in early stages, it can by itself improve a lot of the symptoms with Parkinson's. Then there are other group of medication called COMT inhibitors. Those basically help levodopa work longer. So what they do is they minimize the breakdown of the levodopa, and therefore they help levodopa stay longer into the brains, and therefore they improve with those fluctuations that may come on. Other group of treatment options are MAO-B inhibitors, which work on whatever existing dopamine is available, and they minimize the breakdown. So again, it helps to keep the levodopa or dopamine more so in the brain available, and therefore improve those symptoms. So, we've known about Parkinson's disease for almost 200 years. For the first 100, we actually didn't know how to treat it. Then we first tried to synthesize dopamine in 1910s, but really 1960s when the levodopa was first ever, approved by FDA. And that has really changed the way we treat Parkinson's these days than we used to. It's been, good 70, 80 years since the levodopa was, first come out. Since then, some new medications have come on over time, but that still remains the best medication there is to treat Parkinson's. Other medications, we talked about the COMT inhibitor, such as entacapone, other combination medication, the dopamine agonists, they came on in the 1900s and the early 2000s, which again are of benefit. And so either you try them in early stages or you add them later on to let the levodopa work better, depending on what sort of symptoms patients are having. And in late 2010, mid 2010, other different formulations of the levodopa came through. So the idea is, as the disease is progressing, the brain is losing the neurons that not only produces the dopamine, but also process the dopamine that we're giving from the outside. So because of that, what happens is, medications that were utilized well enough in the past, now the brain is not able to utilize them as efficiently as it used to. And because of that, people develop these fluctuations in their symptoms. And then sometimes it gets too much into their brain. And that's when they have the excessive body movements, such as those are called as levodopa-induced dyskinesias. So with that, the idea is, okay, what if we gave a smaller but frequent doses of the levodopa to the brain? Now that would mean, either you give Rytary, which is basically a combination of immediate release and a controlled release to help with these fluctuations, or you do the gel form, the Duopa, where basically we're giving the carbidopa levodopa in a gel form through the tube into the stomach, and is delivering a small, slow but continuous release of dopamine. And those are some good options to help the fluctuations via medications. Sometimes people have these sudden offs, like, okay, I was doing well, and then the medication stopped working, and you're still not ready for your next dose. In those situations, something like Inbrija was approved, which is inhaled form of levodopa. So it starts working within 5 to 7 minutes and provides temporary relief until you bridge to the next dose. And then more recently, another medication was approved called Nurians, which works slightly differently, but again works with levodopa to help the levodopa work better. So there are some of these medications that are available in the market that we utilize often to treat initial symptoms and the fluctuations. This is how the fluctuations look like. When initially in the journey, for first few years after the diagnosis, majority of the patients, as we start the medication, they do fine. Most of the times we prefer that they take 3 times a day. And when we say taking the medication 3 times a day, you want to take it in your awake hours to get the most out of it. So as you can see, the dopamine levels tend to fluctuate in the brain. And as you give the medication, so the yellow squares are the medications, and that helps peak the levels of dopamine in the brain, and that helps improve a lot of symptoms of Parkinson's. But sometimes as the disease progresses, then people start experiencing that between the doses, they start to feel slow again, or the tremors come back, or the balance gets worse again. And then they have to take the second dose, and then it slowly starts to peak. And it can vary in different individuals depending on what dose they are taking, what's their level of activity, how far they are in their journey, and again, what type of Parkinson's they have as well. So there are a lot of factors that decides how these fluctuations can affect individuals. But as the disease advances, then it becomes even harder. The big thing in this is it becomes much more unpredictable. First, when you take the medication, people didn't realize that, oh, there were fluctuations. Then they became aware of the fluctuations, but then as they took the medication, they were still predictable that, oh, this dose is going to kick in 15 minutes. I'm going to be fine, or I'm going to take an extra dose, or I'm going to take an extender of the levodopa and such. And that usually helped. But now it becomes a time that some doses kick in really well. Some doses take a while to kick in. And as they kick in, they just kick in too much. And sometimes that's when it leads to those excessive body movements known as dyskinesia. And as the day goes on, some doses just don't kick in, and that's called a dose failure, where you still feel off until the next dose. And then the next dose kicks in rather very quickly and then crashes rather very quickly. And then you can see that there is no clarity as to how each of this dose is going to work. So the TW, or the therapeutic window, that is a time between you feeling off to you feeling on, meaning you're not having any symptoms of Parkinson's, and then having dyskinesia. So it's a very small time gap between feeling on and on with bothersome dyskinesia. So that window gets smaller and smaller as the disease progresses, and more importantly, becomes more unpredictable as the day goes on. So this is why, this is where the role of the advanced treatment options come in. So let's kind of look at different ways of how we say somebody is off or on. So let's start with the off video. So you can see the center video where the individual is walking. They have a tremor in their right arm. They're kind of taking smaller steps. Almost feels like they're running and the body is kind of moving forward. So that's what we say when somebody is off, that they have less dopamine in their brain, and therefore they have more symptoms of typical Parkinson's, the resting tremor, the shuffling gait, and the slowness. Now, a good on time means that their tremors are good. They may not be as bad as they were, and the walking improves quite a bit. And here they are running on purpose. You can see that, look at that, the distance between the two legs is much, much better. And they're not having dyskinesias. Whereas here, they are on, they took their medication, they're not shaking, they're not having the tremors, but they have this abnormal, involuntary, jerky movements that can be anything that can affect either the head, the neck, or the arm, or even the lower body. It can affect individuals differently, and this is involuntary. Typically happens a few hours after they've taken their dose. So the tremors are gone, the slowness is gone, but they still have some issues, and these are called dyskinesia. So often they do fluctuate between these three states quite a bit without necessary timeline. And sometimes those get very blurry and they're hard to say. Many a times we see patients that on one side, they're actually having tremors or shaking, and on the other side, they're actually having dyskinesia. And at that point, we know that we have tried our best to optimize their medications the way we could, but it's still just not enough. And that is where the role of the deep brain stimulation comes in. So I think that hopefully makes it clear about the off and on. But what I tell our patients, or what we tell our patients, is we need to be careful at tracking that. So first we need to understand what we mean by off time, on time, and dyskinesia. And then usually we say that, okay, create a diary. And there are different ways to create that diary, where every 30 minutes or an hour, you kind of write down whether you're feeling off, on, or on with some bothersome dyskinesias. And then when you go back and see your neurologist, you talk to them about those issues so they can then better address those problems. So that's the biggest thing that you need to keep in mind, especially as the disease progresses. So, again, majority of the patients will have that off time somewhere in their journey of the Parkinson's. However, they still fail to discuss these symptoms with their doctor. So it's very, very important that you discuss that with your neurologist visit. Every time you go, that's how the conversation should at least begin. That, okay, this is the amount of time I'm spending feeling off, or this is the amount of time I'm spending having dyskinesias in a day. And that's why having a diary always helps. So we talked about some of this, that, initially when the fluctuations come on, we can adjust some of the medication. We adjust the timing of the medication. If the fluctuations are that the medications are not lasting long enough, then we can add a medication extender. If you have a dyskinesia, then we can add a medication to help treat the dyskinesias. Then we could try the Rytary or other combinations of the medications. With all this, there are still limitations that even despite of all these advances, there are still patients who continue to have the unpredictable response, or they continue to spend a lot of time with dyskinesia. And as I told you, there are many times we see patients who are having both the symptoms of off and on at the same time, despite of optimal medication management. And this is exactly where the role of the DBS comes in. We've been doing the deep brain stimulation surgery for over 20 years, and we have that data that it is a very effective treatment for treating Parkinson's patients. And in patients who have these fluctuations and dyskinesias, it has the largest effect on the quality of life when compared to just the medication. So it's very important that we discuss that as a way of improving quality of life. So let's talk a little bit about DBS for Parkinson's disease. Again, the idea is that Parkinson's happens due to abnormal neuronal firing because of that lack of dopamine that we talked about. So the idea is, what if we took over that abnormal neuronal firing by increasing the frequency of those neurons? So basically, what if we stimulated those brain areas with a high frequency? And what we found is that it could reduce the symptoms back in the 30s. Then they developed these stimulators in the 70s and 80s. And it was 1990s that was when the pivotal studies were done to show that the DBS was effective to improve first the tremors, and then later on a lot of other symptoms of Parkinson's. So we recently celebrated 30 years of DBS, knowing that it has been very safe and effective treatment for a lot of our Parkinson's patients. Since then, in the last decade or so, a lot of advances have come in, especially the directional DBS system. And we'll talk about that a little bit more in few slides. And then, of course, the virtual programming that was also approved in around 2017, 2018. So a little bit of information about the DBS system. This is an individual with Parkinson's who had DBS, where their right body is off, and now they're turning off the left body as well. And you see that within few seconds, they start to notice severe tremors on both sides. And they want to go back. They want the stimulation to be turned back on again. Okay. And again, they just turned on one side. It was just turning on the left side.
Look at that.
And then later on, you can see that it can improve tremors quite significantly and pretty quickly. Okay. So what is DBS? It's a brain surgery where we stimulate very specific areas of the brain. And by stimulating those specific areas, we are hoping to stabilize those circuits, especially those that are affected in Parkinson's, and thereby it reduces the involuntary movements. So it's like a pacemaker, but more in a way that it provides that electrical version of the dopamine. The good thing about the stimulation is that we can change it, we can temporarily stop it, and we can program it and adjust it, especially as we are dealing with a progressive condition. It gives us that ability to program and adjust over time. And we know it provides improved quality on time. It provides much better tremor control than the medications, and it improves the dyskinesias and the fluctuations. And it does help reduce reliance on the medication in some cases as well. So what are the symptoms that get better with the DBS? The tremors, the stiffness, the bradykinesia or the slowness, and the dyskinesias. These are the motor symptoms that primarily improve with the help of the DBS. We want to establish that some of these symptoms are getting better with the levodopa. So that's why the first important thing is we want to make sure that you're at least showing some improvement on the levodopa, meaning the slowness is getting better, the balance is improving, and then some patients also do develop the dyskinesia. So we have to ensure that some of those things are happening. The tremors, it's okay if the tremors are not going away all the way, but at least we want to make sure that the slowness and the stiffness is improving with the levodopa. So we want to see at least 30% response when we're deciding the candidacy for the DBS. Things that may not get better with the deep brain stimulation is the speech difficulties, the cognition, the cognitive abilities, the swallowing, the smaller handwriting, the gait, and the balance. Though, especially the freezing, those things do not improve directly or may not improve directly. What we tell our patients is that that's one of the reasons we want to do the off and on testing, where you come in for at least, where you're off of your Parkinson's medications for at least 12 hours. Then we examine you without any of your Parkinson's medications. We then give you the medication in clinic and then wait for an hour or so for it to kick in. And we can then see the difference, not only how much improvement is there, but what is getting better, to what degree, and what are the effects on the balance, and what's happening with dyskinesia. So we look at all of that, and then we discuss together as to what will get better, what may not get better. So the biggest challenge is to make sure that we discuss the expectations, and the expectations have to be discussed in the right way with every patient for us to have a successful outcome. So what are the typical candidates that go through the DBS? They've had the typical, meaning idiopathic Parkinson disease symptoms for at least 4 years, that they are a good candidate for surgery, meaning that we showed that they had at least 30% improvement on their medications, and they're having these fluctuations in their day-to-day life, or they have severe dyskinesias, or we have tried the high enough doses of the medications to improve those fluctuations and they're not better, or the tremors are not better despite of the high dose of the dopaminergic therapies. So those are the ideal candidates. Those who have milder symptoms, or those who are early in the disease and the medications are enough to control the symptoms, are, you can wait for those patients. And those who have really severe symptoms, meaning their balance just does not get better with the medication, or they're starting to have a lot of cognitive issues, then those are the patients who are not ideal candidates. So it's a very evolved process that people have to go through a lot of evaluations to make sure we are looking at all this information together. Once we decide that a patient is a good candidate for the DBS, we then take them through the surgical process with our functional neurosurgeon. And what does, or how does a DBS therapy work? It is basically a three-piece system. Think of this as a generator, a pacemaker-like device that sits in the chest. And from there, an extension wire runs through from the shoulder, underneath your skin, behind the ear, and then goes through a brain through 2 small incisions on either side of the brain. And 2 small wires go into the very specific area, and those are called the leads. And those leads are delivering a targeted stimulation to very specific areas of the brain. And the idea is, as we stimulate those areas, it provides improvement in the involuntary movements by stabilizing those brain signals. So again, a lot of processes involved in this. We do the off and on testing, neuropsychological evaluation. At our center, they also do physical, occupational, and speech therapy evaluation. We discuss caregiving concerns. We discuss expectations. And then we all of us meet every 2 weeks to discuss ideal candidates. Once we decide who the ideal candidate is, then they meet with a neurosurgeon, who then looks at the brain MRI to plan and make sure that we have a trajectory. On the day of the surgery, a halo is put around the head of the Parkinson's patients. Depending on where center you are at, most of the patients end up getting shaved head. And then you get the halo put in. You get another imaging to make sure that the halo is in the right way. And then we slowly create a small incision on either side and carefully implant the lead. Generally, we do 1 lead at a time. And as we are going through, majority of the centers, patients are awake because we want to see the different signal that comes in the brain as the surgeon is going through different areas of the brain. The good thing is that brain does not have pain, brain itself does not have a lot of pain receptors. So once we are past the skull, which we have given enough local anesthesia for, patients don't feel a lot of pain or discomfort. Of course, they feel the drilling portion and they feel that something is going in, but it's not as painful. And the teams are very experienced to keep the patients very comfortable as these procedures are being done. Once they know that you're in the right spot via the specific signals in that area of the brain, they want to make sure that the lead is in the right place. So they do the electric stimulation. They also want to stimulate the brain at that time. So that's why it's another reason that you're awake. So they are not only looking to make sure that the tremors, the slowness is getting better while we are stimulating that area, but also to make sure that there are no other untoward side effects of double vision or some new numbness or tingling or anything like that. Once they know that the lead is in the right place, they then secure the lead to the top of the skull, then they close out the skin. And usually after that procedure, now depending on which center you are, here we do both the leads on the same day. So once the one side is done, then you do the other side and you close out the skin. And then most of the times patients are sent for one night of overnight stay. Most of the times they're in the ICU. We're just watching you very closely. You're not necessarily connected to a ventilator or any other tube. And then the next day, if things are okay, we do another scan and then you go home. Generally, then the second stage comes in. For this one, majority of the centers, you are asleep, because what we're trying to do is then create a tunnel from that area where we had the tube fixated to the skull, and we create a small tunnel underneath the skin behind the ear, and then that connects to a battery pack, and we create a small pocket in the battery pack. And once this is done, obviously you wake up, and if you're feeling okay, most of the times you go home the same day. And generally most centers will have some time between the stage 1 and stage 2. Okay. And once that is done, they want to make sure that the battery is connected well. They will make sure that the system is working okay and everything looks good. Generally, what happens is between 3 to 5 weeks since after the procedure. So typically a month after the stage 1, you come back to the neurologist's office where we do mapping of the leads. What that means is each lead has about, depending on what company are we choosing, generally we have about 8 electrodes on either side. And we're checking at least major 4 of those electrodes to figure out which electrode gives us the best control of your symptoms with causing minimal or no side effect. So this is the longest visit with your neurologist, and they will make sure that they identify at least one of those electrodes. So out of the 4 on either side, all you need is one of them to be, in the right spot to be able to get the most benefit. Majority of the times, the surgeon do a fantastic job where at least 2 of them are in the meat of the area where we want it to be. And once we start a slow stimulation in the first visit, then over the next few weeks, we do additional programming to optimize. So generally what we say is takes few weeks before you're optimized since the surgery. So all of that happens very carefully in your neurologist's office. And then depending on how you do it, but typically with Abbott, it does provide the virtual clinic, meaning you have a controller that you're able to program even remotely. So you could be in the comfort of your home, and the clinician could be in their office or wherever, and you can connect securely remotely, and they can program the device in sync. And we'll talk about that as to how that happens over time as well. Okay. Oftentimes we get that question is it covered? Yes. Most public and private insurances, including Medicare, cover the deep brain stimulation. So most of the times the doctor's office that is working with you will go through all that with you. always talk to your doctor's office and insurance company about what your cost may be. And most of these clinics should be able to give you an estimate on your side. Again, I usually say, at our institute, we give them a full bundle cost of the pre-DBS visits, the surgery itself, and the post-DBS visits, all kind of combined. That way, most patients know what they are what they may be responsible for, as it's a very involved process. A little bit about potential side effects or complications. So as of now, primarily it is used for Parkinson's, essential tremor, and dystonia. Generally, we want to try the medications first, and if either medications don't work well or they cause some severe side effects, that's when we talk about the DBS. We always say that DBS is an adjunct to the treatment for Parkinson's with the medications. It's not an alternative to the medications. And you want to make sure you again discuss what are we trying to achieve with the DBS. It has its own set of risks and complications. So most important things to discuss would be, potential for bleeding type of stroke, which can lead to paralysis. It can cause sometimes infections by delayed wound healing. Sometimes the leads may be not in the right spot, so that may cause some stimulation related problems too. These numbers are very small, and you should always discuss with your team as to what their complication rates are, so that way you can get an idea whether to move ahead or not. Some other things to be mindful of: patients who get the DBS, we usually say some of the restrictions, primarily like, okay, we don't want you to do a competitive swimming. You can do a little bit of swimming in a controlled environment. Also reasonable caution to be exercised when bathing. While we are stimulating, some other side effects to look for, primarily with Parkinson's patients where they have the leads, they may have double vision, they may have numbness, they may have balance issues. Sometimes the depression may get worse, or they may become suicidal. Again, these are very, very rare. And with an experienced DBS programmer, usually we can mitigate that with adjustment of the DBS. But that's something to, again, discuss with your doctor when you're discussing these procedures. Sometimes the good thing about the DBS is the reversibility, meaning if you have any severe side effect, the first thing you can do is you can turn it off yourself and see if it was the DBS that was causing the side effect. Typically a side effect that is due to the stimulation, that'll go away the moment you turn off the device, most of the time. And if it's something that your programmer has tried and they just couldn't get around, then they can discuss whether they want to go ahead and remove the whole system or just leave it in there, because you're just looking at another surgery if you were to remove it. So discuss those options carefully too, in case if this happens. Fortunately, it's very rare that it happens. What are the advantages of the Abbott's DBS system? But let's look at what happens with the stimulation when it's on. We saw one example in the past. This is another example. We looked at the tremor. This is the benefit of the stimulation on this individual's slowness and balance. As you see, when the stimulation is off, they're taking smaller steps. Their left arm isn't moving as much. And I don't know whether this video was taken so this was off medication, off stimulation. So remember, even they were not on the medication when this video was taken. When you turn the stimulation on, and most likely the medication's also on, you can see almost normalized walking. And you can see that shuffling is gone. They're moving their arms well. So very impactful, changes. But again, this needs very careful discussion as to what the DBS may do in particular. So as you saw in this individual, that they were still on medications too. So reminder that it's an adjunct to the therapy. Things have really changed over the last few years, especially with our Abbott's DBS treatment options. We can do a lot more. So the Abbott DBS system consists of several things. This is the burr hole cap that basically sits at the skull that is helping secure the lead in place so it doesn't move. Then you have the stimulator that is a generator that provides the power. So that's like that pacemaker-like device that sits in their chest. This is an extension that connects the lead to the battery pack. This is the iPad that is typically the clinician programmer, and then an iPhone, which is the patient side. So usually you get an iPhone or an iPod, and then clinician gets the iPad, and you're able to do a lot of different things with that. And this is how the leads look. Number 5, you see, so each lead has 8 electrodes on either side. And what that means is there are 4 electrodes, and the second and the third, they're kind of divided, so it can provide us the option for directionality. So what is directionality? And this is something that has been recently approved. What we're trying to do is when we are stimulating an area, in the back in the days, we always used to create that sphere, so it would cause some untoward side effect in some patients. But with directional leads, we're now able to direct the current to a very specific area of the brain in a more efficient fashion. Therefore, we can help minimize the side effect and provide more efficient programming. So again, as you can see, we have the ability to move the stimulation to a very specific area of the brain. And this has been studied extensively, that, recently a trial was concluded that showed that when we use the directional leads, 9 out of 10 patients preferred to be on the directional lead compared to the conventional DBS, which was the whole, using the whole ring of that electrode. And majority of the patients had minimal side effects due to the directional leads. So again, a lot of discussion with that. So it can provide a lot of improvement in day-to-day symptoms, relatively low maintenance, and minimizes the need for continual medication use, etc. It is MRI compatible, so we just want to make sure that you do it at a center that is experienced to do the MRI. And it has the MRI safe mode that you can control it from your device itself. In the interest of time, I'm just going to quickly jump to the virtual clinic. So this is a very unique situation with our Abbott programmers that we can provide care remotely. A lot of times, a lot of patients are traveling to the DBS centers, and sometimes that's the biggest barrier in getting the surgery. But with Abbott, what it does, it allows us to program you remotely, so that minimizes the need for travel. It is a very secure way of connecting with your doctor, and it happens in real time. So it's not like we decide to program you today and you're not even, with me at that time virtually. We have to initiate the session at the same time and do it under a medically encrypted app. That you and I have to be doing it together to be able to do the programming. Okay. And it's real time. It's not like, we did something and you will feel it later. And this helps minimize a lot of visits. Sometimes those urgent visits that are needed. Oh, well, something happened and my symptoms are worse. So can we look at this again very quickly? So it has been really, really helpful and in providing that personalized care to a lot of our patients in a very secure fashion. And this is just one of the ways how to establish a connection. You have to be both on at the same time. Then you get a request from the physician that we want to connect. You have to approve that request, and that's how you see each other. On your phone, it would look like this, and on my side, it will look like this, and we can make the adjustment in real time, look for any changes, and then make the final settings. It also has a lot of different safeguards so that in case of loss of connectivity, you do go back to your previous settings. So it's not like a lot of loss as such. Okay. Remember Olson, just his story?
And I wish I had done it earlier. I really did. I could sculpt again. I could do my digital painting, all kinds of writing. I couldn't do any of those things before. I still have Parkinson's, but nobody knows it. That in itself is a huge thing to be able to interact as a normal person. Just be normal. That's all I want. That's not a lot to ask. The game changer really was being able to get back to sculpting and to have that fine motor control that I never had in the past. For 10 years now, I've been waiting for it. And all I used to say to myself, I could just have one day, just give me one day. And now I've got every day. It's amazing.
All right, as we say, this is our motto, right? As we are treating our patients, giving back your life one day at a time. And this is so true for a lot of our patients. This is just some information to help you find a movement disorder specialist near you, or if you want to talk with a DBS patient about their experience. So these are the scannable codes, and you can use this. And I'm sure we can send these later for your use as well. I'll stop here. I know we are over time, but I'm happy to take questions. Feel free to ask questions. We'll go.
Yeah, we do actually have questions, and I just want to call out Carl and thank him from Abbott. He's been answering some also, knowing probably that we were running a bit behind and we probably have more questions than we have time for, but I am going to ask you a couple of them. So one is related to symptom management. So there was a question of whether DBS can have an impact on things like GI function. So if somebody has urinary or GI issues related to stiffness of their bladder or colon, can DBS help with that?
No, so it does not. As of now, we don't have any evidence that DBS will help with the bowel or bladder functioning as such.
And another question, does it have any impact on depression?
So it has been looked at, and again, as I mentioned in the talk, that some patients may develop acute depression, and there are some reports that over 10 years, some people may develop slightly more depression. That's one of the big reasons. Majority of the patients we take, all the patients we take through the DBS, we go through a detailed neuropsychological evaluation. If there are concerns for mood issues, one, we first try to address them, and two, we choose the target really depending on the neuropsychological profile. For example, we may not do the subthalamic nucleus or STN DBS for those patients who may be more prone to depression.
And the question just came in about whether, because you were talking about, some of the criteria that you look for and how you, it's a clinical diagnosis and you might use a DAT scan or skin biopsy for diagnosis. But this question is, if someone is later on diagnosed with an atypical form of Parkinson's, can they have DBS?
So as of now, we don't have any evidence that the DBS helps actually the atypical. So that's actually one of the big reasons we wait for the 4-year period that we talked about, because sometimes it may take a few years before the atypical Parkinson's kind of shows up. So no, the DBS does not help with atypical Parkinsonism.
And so we know that if someone is maybe over-medicated, they can get dyskinesia. If you're overstimulated, can you have dyskinesia?
So it really depends on what target are we choosing. I don't know. I mean, the overstimulation is not necessarily a right word. Sometimes the STN itself, when you are in the right spot, in very few set of patients, even just a normal amount of stimulation can actually cause really bad dyskinesia. And that's actually one of the reasons we are able to reduce the medication, because now we have more stimulation related dyskinesia. So we'll lower the medications, and then that'll help minimize overall dyskinesias and the medications as well. But generally with the other target, with the GPI, it usually does not cause dyskinesias. If anything, we often use the GPI as a target if patients are struggling more with dyskinesia. So really depending on what symptoms they have, we choose the target. So for more tremors, we usually choose STN. For more dyskinesia, we choose GPI. Again, there are a lot of other factors that goes into that decision making.
So I have a couple of questions related to time. One is if you mentioned like a 4-year time frame. If it took a while for someone to get diagnosed, like Olson, I think, mentioned in his video, it took him a while, but they've had symptoms present for a long while. Is that part of the consideration in that timeline?
I agree. So when we talk about time, we do talk about a window. So as long as the the neuropsychological profile is relatively intact, and as long as we understand what are we really trying to treat. For example, many a times in many advanced Parkinson's patients, they have severe balance issues. And if they don't get better with the medications, then the DBS is not necessarily going to help. So if they are far advanced in their timeline, then yes, the DBS may not be suitable for those particular symptoms. But even if they are far away, but they have lots of tremors, lots of dyskinesia, and otherwise intact neuropsychological profile, we don't necessarily look at the timeline. The timeline is more for that minimum 4 years of disease. That's what we are trying to say. Back in the days, it used to be 7 years, but because we have identified that DBS is very helpful in improving the quality of life of some individuals who have these fluctuations, we were able to move that timeline up to 4 years. So idea is minimum 4 years of Parkinson's symptoms and not maximum.
So the other time question is, how long are people living and functioning after having DBS? It's one. And then the others, how long do the batteries last typically?
Both are good questions. So DBS does not change the trajectory of Parkinson's disease per se, meaning it doesn't prolong the Parkinson's progression as such, and it does not prolong the life. However, at this point, we have at least 20 years of data from the DBS that even though the disease may progress, the certain symptoms of Parkinson's continue to remain beneficial from the deep brain stimulation. So hopefully that answers that question. About the battery, typically, majority of the battery lives are between 3 to 5 years. Now, majority of the companies are coming up with a rechargeable battery that it's like a phone. You have to charge it on the chest, and then that can last for 10 years. With Abbott, we will likely have some of that available next year as a rechargeable battery.
Lovely. And I think this question was asked earlier and may have been answered in the chat, but I'm going to bring it back up again. And they're wanting to know if somebody's non-tremor, but they have dystonia, does this work for dystonia? So
actually, just having dystonia, not even having Parkinson's, the DBS has been FDA approved based on humanitarian grounds, knowing that certain dystonias do get better with the deep brain stimulation surgery. We often actually use the DBS to treat dystonia related to Parkinson's as well. So yes, it does help the dystonia. But again, you have to be careful. What are we saying? What dystonia is? So again, make sure you discuss that with your neurologist. And what body is it really affecting? So you have to be very careful with that too.
And then there was a question about whether someone needs to have their own iPhone for this system.
They recently upgraded from iPod to iPhone. There is an app available on the Apple Store to download. However, you have to remember it's a medically encrypted device, a medically encrypted app. So every time the Apple gets an upgrade, the app may not be upgraded. And sometimes that may create a conflict. So just to keep safety in mind, I usually still say, I would say keep those two things separate. Use your controller still as an iPhone, and then you can use your own personal device separately.
Awesome. Well, I know we've kept you over like 10 minutes, so I want to honor your time, but I want to thank you so much for spending this time and delving into all the symptoms that it addresses and how the system works. I really appreciate your time and your expertise.
Thank you. Again, thank you so much for having me here. This was great and a lot of interesting questions and very engaged community. We're here for you and we're in this together. So let us know if there's any way we can help.
Absolutely. So we thank you. And we, of course, thanks Abbott. So you're new to PMD Alliance, so you're not aware of this, but we have a tradition within our community as a way of thanking our speakers. I invite everybody to turn on your video if you don't have them on yet, because I want to give Dr. Lotia his first official send-off with the wave of gratitude. So we wave to you from all across the United States and even beyond, as thanking you so much for your expertise.
Oh, thank you so much. This means a lot. I really, really appreciate you all being here. This is very impactful. So again, thank you all for being here.
Thank you. And thank you everyone for joining in. We take care and have a great rest of your day.
Bye-bye.